Good day everyone, I am Michael, the moderator for this webinar. I welcome everyone for today's webinar, which is Medical Records Chapter, Meeting the CMS Hospital CoPs and Access Requirements. It's a great pleasure for me to introduce our presenter for today, Laura A. Dixon. Laura A. Dixon, BS, JDRN, CPHRM, was COPIC's Director of Facility Patient Safety and Risk Management and Operations from 2014 to 2020. Ms. Dixon has over 20 years of clinical experience in acute care facilities, including critical care, coronary care, perioperative services, and pain management. I would now like to hand over the floor to the speaker. Over to you, Laura.
Okay, thank you very much, Michael, and welcome everyone. And by the way, I did include CMS's site email addresses for you if you want to reach out to them directly. I'm going to do a brief introduction of why we're here. Those of you who've had the experience of going through a state agency or a state survey, you know you don't want to get one of these. We have three types of surveys: certification, complaint, which no one wants to get, and a validation. How do you keep up with the changes? I would suggest you subscribe first off to the Federal Register. I have held the links, by the way, here on this slide. One thing I'm going to touch on briefly today just came out yesterday, and it talks about informed consent. And that will only be in the surgery section. The overall manual that we're going to be talking today is Appendix A. Psychiatric hospitals were weaved in back in 2020, so you are part of that also. And criticals, you are Appendix W. Here happens to be the deficiencies of the information we're covering today. Before I go there, I do want to talk about patient rights because this continues to be an issue, and that is access to the medical record, the information. You know, they get it in whatever format they want, whether it's electronic or old school hard copy. They get their records. This is the actual hard record. They get it in a timely manner. We know it's 30 days. There are proposed regulations. Otherwise, Office of Civil Rights says if you don't get your records timely, you can file a complaint with us. Other rights the OCR has for patients as it relates to their medical records. Well, really quickly, interoperability and the patient access. It's referred to Open Notes, and that was from the Cures Act. Really, the rule says you have to establish a secure application for interface requirements of this healthcare information. So here's what has to be available. So with limited exceptions, and that's very limited exceptions, we have to make sure patients have access electronically to their medical record at no charge. But speaking of blocking, I do want to talk about it because we can't get away from it. If you are blocking a patient's access or exchange of their information, and you know that practice is unreasonable or interferes with their access, then it's considered blocking. There are 4 exceptions when your practices do not meet the qualifications or the definition of blocking. And of course, it has to be a reasonable block, no broader than necessary. What you're doing is based on clinical or other expertise and is consistent and non-discriminatory. Second one, privacy exception. The third one is your security exception. All right, let's move on over to the conditions for participation. First off, you have to have a service that has a responsibility for your medical record. And the record includes everything that goes on with the patient. You have to have an organized department that's appropriate for what you do. I mentioned you have to keep a record for each patient. We have to protect our records. We have to have a way that we know who's writing in the chart. We have to keep our records in the original or legally reproduced form. The surveyor, they'll make sure records are kept for at least 5 years. And of course, we have to prevent unauthorized access. Federal state laws may require original records to be released. Again, your content has to have enough information to justify why the patient's there. It has to be legible. Here they say legible. CMS hasn't quite accepted that we don't handwrite certain information. So that's okay. We just want to make sure we can read it. Every entry has to be timed. This is a very problematic standard form. Practitioner, they have to date and time, authenticate. Briefly on rubber stamps, just say no to them. Another thing you can't do is what's called auto-authentication. Verbal orders have been an issue for safety, patient safety, and those are 2 different tag numbers, 407 and 408, and they really talk about what has to happen when a nurse is taking a verbal order. Standing orders, that's a little different. You can use them if that's what you want. You need to have the other 3 components, medical, nursing, and pharmacy, review it and act on it in the final report. You have to have a history and physical completed and in the record no older than 30 days. There's also in the medical staff chapter. This is tag 358. The record has to have the diagnosis in the chart, any consults, make sure they're done quickly, informed consent. There are 3 separate sections within the entire manual that talk about informed consent. First one is patient rights. The next one is the medical records, what we've been talking about, and surgical services. Now here are the minimum necessary requirements. Optional elements that you can include. The surveyor want to make sure that the staff has that list of procedures and treatments, those who require consent, and what the record has to include. But it also has to have a discharge summary. That is a requirement. Now, I want to point out these next 2 items, and there's other sections that I do want to point out. Don't forget documentation when you're doing restraint seclusion. Medications, pre and post-op evaluation. Now I'm going to focus on critical access hospitals. I have the tag numbers listed. So what I just want to point out are some of the highlights. 1, you have to have the same information according to what's applicable for that patient's visit. As with your acutes, your records have to be complete and legible and readily accessible. Records have to include not only patient identification, but social data. And now the same thing as far as what was in the acute for consent, it's the same for critical access. And again, the properly executed form, this is what has to be in there. Overall, the record has to have enough information to, again, support why was the patient there. And likewise, you have to have a discharge summary. Surveyor, they will make sure your staff, your medical staff, specified what procedures or treatments have to have a consent form, and likewise history and physicals. Now I have a question here from CMS that I wanted to add because it did come up, especially for critical access hospitals. And then we have to have enough information on how the patient responded. To orders, medications, they have to include everything. Our entries must be dated and timed and authenticated, and your policies, your medical staff policies specify who does that. Keep your list of computer codes and written signatures. We have to authenticate entries. How are you going to do that? They want confidentiality. So I want to talk briefly about the breach. Our notification rule, because this will be a headache for you. High-tech, ARA, they did strengthen security protections for health information. So here's your objective risk factor. And by the way, you now have to do a security risk assessment. A record-setting large security breaches in healthcare 2023. So we have the security rule requirements, but you have to put policy and procedures in place. So you have to conduct an accurate and thorough assessment of any potential risk or vulnerabilities, the scope, really look at what are your potential risks. So just a couple of things to follow up. Copy paste, this still occurs. Joint Commission, they also have it. There are certain improved efficiencies. So finally, I'm going to put this out here. Texting. We know, and we do it, usually probably do it, your computerized ordering is a preferred method. You have to utilize and keep a system that is secure and encrypted.
Thank you, Laura, for the great presentations.
Okay, thank you, Michael. And again, thanks everyone for attending.
Once again, thank you, Laura, for the great presentations. So that does conclude the session for today. Thank you everyone for participating. You may all disconnect now. Have a great day ahead. Bye-bye.